I'll be talking about neuroprotection in glaucoma. We all know that glaucoma is a neurodegenerative disease where there is a characteristically damage to the retinal ganglion cells and their axons. And we have a lot of patients, as glaucoma specialists, we see a lot of patients who have their IOP somewhere in 12, 13, but still they're progressing. So we know that lowering IOP may not be just alone be sufficient. So this is because obviously there are multifactorial factors which are causing this apoptosis and damage to the RGC survival pathways. And they can be in the form of problems in the axonal transport, neurotrophin degenerations, glial activation path getting activated, various co-inflammatory and oxidative stress which is coming in causing this RGC apoptosis. So the new approach in glaucoma therapy is what is neuroprotection, and neuroprotection is any therapy that prevents, retards or reverses the apoptosis-related neuronal death. And currently available AGMs like pramidine and some other ROCK inhibitors now do offer neuroprotection, but the next generation therapeutics, there are lots of trials going on, which are animal trials, have already been done, and phase 2, phase 1, phase 3 clinical trials for different types of therapies are going on, which are aiming for RGC survival, RGC protection, rebuilding the neuronal corrections, and latest is what is neuroenhancement. So why is the need there? As I already mentioned, obviously the need is there because IOP learning may not be just sufficient. Despite achieving a good IOP control, the patients are progressing. So early neuroprotection may have a role there, obviously in high-risk individuals. And also we are, as glaucoma specialists, we would love to bring back the vision of people who have advanced disease. So obviously the strategies by which this neuroprotection is supposed to work is by pharmacological agents, stem cell therapies, as well as gene therapies. These are the various strategies the way it works. There are various studies which are going on, as I told you, at various clinical trials. Various phases are there. And for pramidine, there is evidence that it works as a neuroprotector, but for the other things, the studies are still in the clinical phase trials of phase 3. For gene therapy is being tried in Leber's hereditary optic neuropathy, and supposedly if this, which is an adenovirus vector associated gene is there, if it works out for that, maybe it can be able to be tried in cases of glaucoma as well. So neuroprotection with topical medications, as I told, we already have enough evidence for pramidine, where it is said that pramidine may halt the visual field effects, which may not work with as efficacy in case we are using timolol as the AGM for our patients. And this effect of pramidine on the neuroprotection is not related to this IOP layering effect, and not related to this ocular perfusion pressure effect as well. So it is a separate effect on its own. For ROCK inhibitors, especially the studies have been there in animal models, rat models, both in vivo and in vitro studies related to the Y27633 ROCK inhibitor, and they have seen that it causes an increased survival as well as a decreased apoptosis of the serum deprived RGC cells. And although these studies have been done in the rat models till now, and also it has been seen that the inhibition of the ROCK pathway by these ROCK inhibitors activates the MAPK downstream signaling pathways that are responsible for, that are used by the ciliary neurotrophic growth factors, which is an important neurotrophin for the glaucoma pathway. So current approaches to neuroprotection, as I said, are strategies. There are 3 ways, there are 3 prongs to it. So one is trying to improve the optic nerve head perfusion. Second is trying to rescue the damaged retinal ganglion cells. And third is for trying to regenerate the optic nerve. So the newer agents, some of which are said to improve the optic nerve perfusion, as I said, the ROCK inhibitors are being supposedly claiming to have some efficacy. In the long run, we still need to see the results with ROCK inhibitors. Studies have been there which have done topically, as well as intravitreal injections are being tried for that. And similarly, we have centrally acting calcium channel inhibitors like nimidopine, which are known to increase ocular blood flow, and as well as flunarizine, which besides increasing the aqueous outflow, they also inhibit the NMDA activity. And then we have the rescuing strategies by use of neurotrophins. We have various types of neurotrophin factors which are available, which can be applied exogenously, or we can use strategies for causing sustained release of these factors endogenously. So, and they are also being used in other degenerative disorders like Parkinsonism and amyotrophic lateral sclerosis. While strategies which are working, these are by exogenous methods, but for endogenous expression of the injected growth factors, we have use of obviously the growth factor genes, which are being used through vectors. As I said, adenovirus-associated vectors is being used as a vector for infusing these genes for endogenous expression. Then we have transplantation of stem cells or progenitor cells into the retina, which are also being done for various retinal degeneration disorders. And then there is genetic engineering to upregulate the tyrosine kinase receptors. A newer device which is right now being in one of the clinical trials is the Renex, which is a cell-based implant, which is supposed to continuously deliver this ciliary neurotrophic factor into the eye. It is implanted into the pars plana and stays there for life. And it has gone phase 2 trials for RP and macular telangiectasias. And currently, it is also under trial for POAG. Let's see what are the results. We are still awaiting the results for that. And then the last strategy which I told is the optic nerve regeneration, which can be done by blocking the inhibitory signals, by improving the intrinsic growth ability of these cells, and by stem cell transplantations. For blocking the inhibitory signals, we have the glial tissues. Glial tissue can release inhibitory signals, molecules that signal the RGC to stop growing. So inhibition of these can be done by using NOGO, which is being investigated for certain spinal cord injuries. Let's see if it can be applied to our optic nerve as well. And we have KET3, which is the ROCK inhibitors, which is again, as I told you, is supposed to inhibit the signaling pathways, which can damage these RGCs, exons. And then we have another strategy is by enhancing the intrinsic growth ability of the optic nerve, where this is a gene therapy-based approach to target the transcription factors. And this is again mainly being targeted for the ciliary neurotrophic growth factor and also other growth factors. And then finally is the stem cell transplantation for the optic nerve regeneration, where but the challenge with this therapy is that obviously we will have to transform these injected cells which we have grown into the RGC phenotypes. Whether we are able to achieve that, we are still under experimentation right now. We have so many experimental studies. We have had so many animal models, rat models, where these studies have been done and where they have been successful to some extent, but we have not been able to translate quite a lot of these studies into human clinical use. This is because we need to use so many pathways simultaneously. There may be problem with the drug delivery systems, as I told you. There may be, we need lots of vectors for that. How much reproducibility will we get in when we're translating into human eyes? And obviously we know the human eye may not be behaving exactly the same as the rat models. And since we know this disease glaucoma is a long disease with a long follow-up, with a slow progression. And finally, the issues of, obviously, the money. The funding is always an issue everywhere. I'll just finish my talk in the end by talking about this neuroenhancement. Neuroenhancement is basically seeking to rescue the cells which are not totally dead, but they are dysfunctional. So it is targeting therapeutic window between the dysfunction and the cell death. So this is a very, very promising tool. And it is said maybe citicoline, certain neurotrophins may be acting, as well as separate electrical stimulation may act at this level, for which it is important to recognize the apoptosis retinal cells by using
VINITA,
this dark,
can you please sum up?
This last slide. By using this dark new technology which is there, which is a non-invasive technology where annexin 5 is bound to a phosphodiesterine, which is utilized as a probe after labeling it with fluorescein, and then an argon laser is used to excite this fluoroprobe, and a confocal scanning laser ophthalmoscope is used to detect these marked fluoroprobes. And by this, we will be able to identify the cells which are about to die. They are not actually become dead, but they are in the stage of apoptosis, and probably we can target these cells as therapies. So to conclude, obviously IOP layering still remains the first neuroprotectant, but there is enough motivation to translate all these animal studies into human studies, and neuroenhancing will, with neurotrophins, holds promise. Thank you.